Hi everyone, I want to talk about insomnia. Have you experienced it? Is anyone around you experiencing it right now? Or you've taken medication because of insomnia? Well, let's go. Insomnia is an independent disorder of sleep with difficulty to fall asleep, or the individual is sleeping but can't sleep for a long time, or the individual wakes up too early. If any of these three will constitute insomnia. Insomnia was formerly regarded as being secondary to a medical condition or psychiatric disorders, or as a result of use of some medications. Insomnia is now known to be a disorder on its own, and that can occur without any underlying illness and can actually precipitate certain medical morbidities. Treatment of insomnia can actually improve many co-morbidities. In other words, insomnia is standing on its own when it comes to its own diagnosis, not only because it could be secondary to any underlying comorbidities. What are the possible risk factors when it comes to insomnia? It could be hyperthyroidism, could be as a result of chronic pain, cancer, menopause, gastroesophageal reflux disease, chronic fatigue syndrome, depression, anxiety, headache, or use of caffeine. Be secondary to alcohol, restless leg syndrome, sleep apnea, jet lag, fatal familial insomnia, asthmatic attack, chronic obstructive pulmonary disease, heart failure with autopnea or paroxysmal notional dyspnea, ischemic heart disease, pruritus that wakes the patient up at night, fibromyalgia with possibility of non-refreshing sleep, post-traumatic stress disorder with hypervigilancy, street drugs that gives euphoria and excitement, decreased melatonin. Melatonin hormone secreted by pineal gland is very useful when it comes to sleep, and when it is low, there will be insomnia. Other risk factors could be brain tumors, giving headache, or increased intracranial pressure, stroke, Alzheimer's disease, Parkinson's disease, diuretics, visiting the washroom or toilet or giant, more frequently including night, waking the affected individual up at night. That's why some of us will prescribe diuretics in the morning so that the individual will have peed enough before going to bed at the evening time. Antidepressants, because they are now switching over from depressive mode to hypomania, if not full-blown mania. Pregnancy, the alteration of the hormone state will also alter many things, including their mood and possibility to sleep as well. That's what we call sleep-wake rhythm. It's a rhythm, and it's called circadian sleep-wake rhythm. That could be set based on how we prefer it, For example, those who have shift work or some family rules or family routines. For example, some families set the goals. You have to go to bed by 9 p.m. So get all the assignment done before 9 p.m. and go to bed by 9. Or in those days when we're at dormitory, the lights will go off a certain hour at night, 10 p.m. light off. So people are forced to be on the bed and everywhere will be dark. So that could be setting the circadian sleep-wake rhythm, because by 6 in the morning, the bell goes, everybody is expected to get up. So profession, e.g. doctors and nurses, they have morning shift, evening shift, night shift. They have to be there, they have to be on their feet. So while going to bed, they set their clock, either wristwatch or on phone nowadays, or table clock, Big Ben, set the alarm there. Military people, police officers could be called at any time, so some will be on alert 24 hours. Pilots, they dare not sleep while crossing the Atlantic or Pacific Oceans. Disorders here could be delayed sleep-wake phase disorder, or advanced sleep-wake rhythm, or irregular sleep-wake rhythm, or 24-hour sleep-wake rhythm with shift work disorder. What are the clinical features of insomnia? Someone is asking me again, why do you need to ask about clinical features? The guy couldn't sleep and that's it. It's true, but it could take different forms. Is either there's difficulty falling asleep, or the individual is waking up midnight or early morning awakening. There's possibility of headache, tiredness, daytime somnolency, because the individual didn't sleep at night and now is sleeping during the day, sleeping while driving, or sleeping on duty. The individual will become anxious, and there's possibility of increased heart-related diseases. It could worsen psychiatric disorders, depression. Depression could cause insomnia, insomnia could cause depression. Confusion, high accident at work, home, or road vehicle or road traffic accidents. For obvious reasons, someone who had not slept for a long period of time now behind the wheel driving and dozes off suddenly could swerve out of the road and hit somebody coming from the other direction, or even end up in the ditch or across the bridge. High weight loss, poor memory, worsening upper respiratory tract infection. As a matter of fact, poor memory is even a major concern for so many people with insomnia, because they will judge themselves before being judged by anyone that I've not had a good sleep, I don't think I'm going to do well today. How about worsening upper respiratory tract infection? If you have taken anything to relieve yourself of upper respiratory tract infection, it's likely going to sedate you, right? Epidemiology. About 8 to 14% of adults will have chronic insomnia. 20 to 30% of adults will have intermittent insomnia. It is more in elderly. Well, I have not gone through the literature to get this far, but my thinking is at the old age group, probably the level of melatonin will keep dropping as we get older. And then at the old age group, 70 and above, there is few level or few concentration of the hormone called melatonin, and with that, they tend to have more trouble, having enough sleep, more in elderly, more in women than men, and even amongst women is more in menopausal women than premenopausal women. Substance abuse can lead to insomnia, and insomnia can also lead to substance abuse, or at least indiscriminate use of hypnotics. And a sad note here is the story of that popular pop singer, Michael Jackson. Michael Jackson was having very serious insomnia, and he hired a doctor to handle that. We all knew how he died, at least based on the news. He was pursuing medications to help him sleep, and he got propofol. How do we make diagnosis? Somebody might be telling me you don't need to make diagnosis, insomnia is insomnia. Okay, we need to know from history. And the history will include depression, history of depression, history of anxiety, history of chronic obstructive pulmonary disease, about heart failure or asthma, history of gastroesophageal reflux disease, or smoking or exercise at evening time. We can have questionnaires through which we'll be able to get the exact picture of the state of mind of the affected person. Polysomnography is not routinely used except when you suspect sleep apnea. Laboratory is not routinely done for the purpose of insomnia, but you can assay the electrolytes and melatonin if it's done at the center, and of course toxicology, because it's possible that insomnia has led to abuse of medications, even street drugs, or street drugs is responsible for the insomnia. So toxicology screening is not out of place. Treatment. The treatment of insomnia will be a long story because a lot of people will need help. Behavioral therapy first. Another behavioral therapy, first thing is to try sleep hygiene. Under sleep hygiene, what are we going to deal with? Okay, we'll tell the affected person sleep only when you need to rest. Regular sleep schedules should be set. You just don't go to sleep by every 7 p.m. and you wake up in between. Make it a routine, not going to bed until 9 p.m. or 8 p.m. or 7 p.m. tonight, then another night you go to bed by 1 a.m. No. So make it a regular sleep schedule. And no exercise close to bedtime. Okay? No coffee at evening times. No alcohol close to bedtime. No smoking at evenings. Eat well before bedtime, because if you are hungry and go to bed, you may not get enough sleep. No TV while trying to sleep. Don't be anxious. Drop the anxiety at the door. Alarm to wake you up at a fixed time so as to get your schedule right. Set a fixed time to go to bed. And of course, the alarm to wake you at a fixed time. Stop taking naps during the day, because by the time you add all your hours together as an adult, once you're able to get 6 to 8 hours, you're fine for the day. And some would have gotten 3 hours naps and be complaining they didn't have more than 4 hours of sleep at night. That is 7 in 24 hours. That's fine. I won't give you any medication if that's the case. If you have 7 hours of sleep within 24 hours, I'm fine. The choice of treatment should be individualized. That is based on co-morbidities and psychosocial or cultural factors. Because people who indulge in certain practices might not be able to sleep. Some people go to their places of worship and they need to pray overnight. How could that person tell me the following day that you didn't have a good sleep when you were standing all through the night till about 3 a.m.? You're not going to sleep more than 2 or 3 hours after. We always explore cognitive behavioral therapy before administering medications because we want to run away from the possible side effects of the medications. Okay, to start with, sleep hygiene, as stated just now, we can have stimulus control, that is, bed is used only for sleep. Can also have relaxation techniques, can have sleep restriction therapy, that is, we limit the time allowed in bed. That would be too troublesome for so many people anyway. So, and of course, cognitive behavioral therapy. So we want to explore all this before we start placing anybody on medication. If we are not winning with behavioral therapy, we can then think of medications. But we have to consider some factors. If this woman is pregnant and in first trimester, we should be careful of possible teratogenicity when it comes to that medication we're about to prescribe. If this individual is boozing, meaning taking alcohol a lot, we have to be careful because of possibility of increased central nervous system and respiratory suppression. If there is liver failure, we'll be worried about metabolism, and impairment of such will lead to accumulation of the same medication. How about renal failure for the same purpose? And chronic obstructive pulmonary disease, there will be possibility of hypoventilation. How about the nature of job of this individual? Is this person an individual who must take major decisions in the morning? We need to be careful about the type of medication we want to give now that will have hangover. So people like that must not take medication that will have hangover. The age, the older we become, the lower the effectiveness of metabolism. Therefore, we are going to lower the doses in elderly. For example, if you want to choose trazodone, you can start with something like 12.5 milligram in elderly, while in younger age group, like somebody around 40 or 50 years old, you can give as beginning with 25 to 50 milligram daily. Okay, we are going to choose from a lot of medications. The short-acting agents are triazolam, Zolpidem immediate release, Zaleplon, Rametinon 8 milligram, that is a melatonin agonist. You can choose from that if you want short-acting agent. Those are the agents that will initiate sleep. Then the individual will continue sleeping naturally because, like I've said, there are 3 stages that we diagnose as insomnia. Is either you can't initiate the sleep, or you have initiated the sleep, you can't sleep for long, you wake up in the middle of the night, or you initiated the sleep, you could sleep up to the middle of the night, but too early in the morning you are awake. So for the first part, not able to initiate the sleep, triazolam, Zolpidem immediate release, Zaleplon, and Rametinon, or even melatonin itself will be good enough. For long-acting agents, you want something that will span the entire night. Ezopiclone, estalozam, Zolpidem extended release, Diazepine, lorazepam, and temazepam will be fine. For those awakening between sleeping hours, they are able to initiate sleep, they go to bed, you start sleeping, but at midnight or just few hours after sleeping, you wake up. Xylapalone, Zolpidem sublingual tab or sublingual spray will be fine. You can give melatonin here also, but somnolency, nausea, and increased warfarin effect will be possible side effects. And melatonin is contraindicated in pregnancy and breastfeeding or individual with hepatic impairment. Note this, melatonin hormone is affected by sunlight. So sunlight to the eyes will lower the level of the hormone secretion by pineal gland. Darkness will lead to normal level of the melatonin hormone production by pineal gland or even higher production. Hence, this medication, melatonin, is good for jet lag. And in elderly who would have probably have low natural production of melatonin. Melatonin is available as melatonin tablets, capsules, or liquids. Lamentium is its agonist. You can choose antidepressants. Diazepine at 3 to 6 mg or trazodone at 12.5 to 50 mg. I put that dosage of trazodone because if I'm dealing with elderly, I will start with that, okay? And of course, cyclic antidepressant, specifically amitriptyline. And you also start low for about 25 mg at hour of sleep. And of course, we need to watch out for side effects of all these medications as well. But if you go low, you might not run into any trouble. Antihistamines. Well, we might use them for the purpose of their side effects, not because they are manufactured for this purpose, no. Benadryl, that is diphenhydramine, Gravol, that is dimenhydrinate, chlorpheniramine, and promethazine. They will all knock anybody who is taking this medication off, but not everybody will actually sleep. Some will take just 25 mg of Gravol and they will sleep for the rest of the night, while some will take the whole tab or even two and they will still be driving without any impairment. I'm not encouraging that, just giving you an example. I have people around me like that. Some of us could not take more than just have a Gravol and they'll go to bed and sleep for the rest of the night. While I've seen somebody close to me taking the whole tab and just driving all around the city and nothing will happen. So it's not everybody that will go to sleep with antihistamines. Orexin receptor antagonist, sulforescent at 10 mg. I have no idea of this medication at all or its efficacy or anything, but I got that through the literature. Non-benzodiazepine, benzodiazepine receptor agonists. Let me repeat. They are not benzodiazepines, but their effect is at benzodiazepine receptors, and the effect there is they are agonistic. They are not antagonists. So when you take them, they are not benzodiazepines, but when you take them, you are going to have the effect like you are taking benzodiazepine. So examples are zopiclone at a very low dosage, 1 to 3 mg, zopiclone to 3.75 to double the dose to become 7.5 mg. Zolpidem immediate relief. You can give it sublingual tab, 5 mg, or sublingual spray is also found in liquid form. Zolpidem midnight, or Zolpidem extended release, that one is coated, and you just give 6.25 milligram, or you double the dose in some people. Xylopron capsule at 5 to 20 milligram. They are not benzodiazepines, but their effects will be on the receptors of benzodiazepines as agonists. Now, benzodiazepines. Many years ago, when the issue was about insomnia, the first medication to think of would be benzodiazepines. You could see that as far as this presentation is concerned, I put them last. So we do many things now, many different types of medication now. You don't necessarily have to go for benzodiazepine as first line, but they are still very, very effective in handling insomnia. Okay, triazolam. I decided to put the half-life here for one reason, and the reason is which of these benzodiazepines will be suitable for somebody who just needs initiation of the sleep and who will not want hangover. Triazolam will serve that purpose. Why that? Half-life is 2 to 5 hours. Okay, and you start with very low dosage, 0.125 to 0.25 milligram. Temazepam will be there for a longer period of time, 8 to 15 hours half-life. Give dosage of 7.5 milligram. And if you compare that to flurazepam, flurazepam will be having half-life of 40 to 120 hours. How many hours makes a day? 24. Imagine that. So when you take flurazepam for days, the effect will still be there. So that is not appropriate for somebody who is working anywhere and is now ready to have medication for insomnia, and you give him or her something that will be in the system for days. Then does it mean you are going to keep him or her at home for days? So flurazepam is not for active, agile people who will need to take decision 12 hours after taking the medication. Lorazepam will be there for 10 to 14 hours as half-life, and estazolam will be there for 10 to 24 hours as well. So triazolam is the best here for short-term purpose of insomnia treatment. Finally, somebody is taking a deep breath. Okay. We need to rule out certain situations when we are dealing with people with insomnia, because they could commit suicide. Yes, either because of the underlying co-morbidities, like somebody that is having cancer and is having chronic excruciating pain, right? And couldn't sleep, might decide to end it and say to him or herself, I can't take this anymore. Just end it all. Okay? So we have to be vigilant and know that this person could commit suicide or not. So not only treating that insomnia, actually have a holistic kind of approach to save that life. Another example is somebody having post-traumatic stress disorder. Ex-military officer comes to me telling me about insomnia, and he or she had experienced frontline combat role before. I'll be concerned about post-traumatic stress disorder as the cause. I will involve and inform the psychiatrist immediately, not to embarrass my patient, but to actually help him or her better. It's not okay to prescribe my Zopiclone or any benzodiazepine and tell him or her to see me after 2 or 4 weeks. No. Suicide is very common, particularly under those situations. How about depression? Manage the depression. If not, from depression to suicidal ideation to attempted suicide or even frank suicide. And of course, anxiety should not be overlooked, should be properly managed. Be careful with the hepatic enzyme inducers. That is another thing we need to watch out for. We have placed this patient on our medication, but the person has been placed on maybe anti-TB medication like rifampicin that will shoot cytochrome P450 into the circulatory system and wipe off the medication I've given for sleep. So the individual will keep coming back. Doctor, you don't know what you are doing. I'm not getting anything from this medication. It's just like a piece of chalk. I'm just going to dump it in the garbage. You understand that? I don't blame him or her. It's because the enzyme inducers have reduced the medication to nothing. So watch out for the concomitant medications or street drugs that the person could be on. With that, I've come to the end of this long presentation on insomnia. You can leave your questions or your comments at the comment section, and I appreciate that. Hope you had a good sleep. That's the question I will ask you before you close this. Did you have a good sleep last night? Okay, I'm wishing you a better sleep tonight. Thanks for listening to my presentation. Kindly subscribe so that you can get my presentations immediately they are published. Thank you.